Hello and welcome to Conversations with Dr. Bachner. This is Howard Bachner, Editor-in-Chief of JAMA, and I'm here with Don Berwick. Welcome, Don.
Nice to be here, Howard. Thank you.
So, a brief introduction. Don is President Emeritus and Senior Fellow at the Institute for Healthcare Improvement. He's also a former administrator of the Centers for Medicare and Medicaid, and a leading world authority on healthcare quality and improvement. But I have to add, on a personal basis, I've gotten to know Don well since I came to JAMA in 2011. He was on the editorial board. He's now on the Journal Oversight Committee. For anyone listening or watching, you should read every single thing Don Berwick writes. He is an extraordinarily magical writer. His use of the English language is remarkable. Phil Fontana Rosa, when we get really extraordinary viewpoints, we call them Berwickian. I would call this viewpoint Berwickian, but it's written by Don. The title of this viewpoint, and this is in the COVID-19 Beyond Tomorrow series, is Choices for the New Normal. And we're gonna walk our way through it, but I just wanted to read from the opening paragraph, and then we'll start the conversation. The severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, has only 15 genes compared with 30,000 in the human genome, but it is a stern teacher indeed. Answers to this questions it has raised may reshape both healthcare and society as a whole. So, Don, you framed the viewpoint around 6 different issues: the speed of learning, the values of standards, protecting the workforce, virtual care, preparedness for threats, and inequity. So 7. Why don't we start with the speed of learning? How is this pandemic going to affect, or the notion of the speed of learning?
You know, as I prepared this viewpoint, Howard, I realized nobody knows. I mean, anybody that says they know what the new normal is going to be is really probably smoking something. There's so much is changing so fast. So I really am trying to frame these as choices. But we are being exposed in this pandemic to a pace, a tempo of learning, change, exchange at a global level that I've never seen before. JAMA itself is an example, although I'm privileged to be associated with the JAMA family, and I have enormous regard for how that whole network runs. Just the pace at which JAMA has been picking up and publishing information, really valuable information. I don't know it must be some fraction of prior tempos, I imagine. The willingness of the workforce to be in touch with each other and learn in these rapid cycles is astonishing to me. And governments are stepping up fast. Some are. I quote in the paper the experience of the Nightingale Hospital in London, in which the convention center, the Excel Convention Center in East London, was converted to a 2,900-bed intensive care unit. It was made capable of that. Between the time they thought of it and the time they admitted the first patients was 3 weeks. It's extraordinary. Now, it's turned out that's been mothballed now. They don't need it, thank goodness, but it's being held in reserve possibly for the next wave. The speed of learning dwarfs what I've seen before. The National Academies of Medicine, National Academy of Medicine of Sciences, Engineering, Medicine set up a standing committee on emerging infections and 21st century threats within days. And it was less than 1 month between the setting up of that committee and the completion of 11 rapid expert consultations. This is the academy moving at a pace it's never experienced before. So I wonder if we're going to change our views of tempo of learning on a global scale. It would be great if we could, because I think the canonical, 17 years from an invention to its use, that's been hanging around a long time.
Don, just to challenge you a bit, could it be too fast? Do we make assumptions that we know more than we really do? I mean, you and I have talked about it offline many times. The modeling, for example, do we put out there that we know more than we really know?
It worries me too, Howard. Yes, of course it could be too fast. And the especially energized by the hope, the need to get some traction on this disaster energizes that we're going to have to find a way to pair discipline, curation, reflection, and science with this tempo. But I think to give up on what we're now learning about how fast we really can move together if we want to, it would be a mistake. What I say is we need to bring evaluation techniques and reflective methods up to speed with this pandemic. In the Nightingale Hospital situation, they developed something called a bedside learning coordinator, BLC. Their intention was to station a named individual for every single pod as both the receiver of news that ought to be put into action and the sender of information about what was being learned. That can be done with discipline, and I think we need to be smart about how fast we move, but move fast.
The second is the value of standards. I'll read something from this section. Clinicians and hospitals want counsel on how to handle the unwelcome ethical dilemmas they may encounter if and when resources reach their limits, such as rationing ventilators. So this notion of standards.
Yeah, one of the understandable obstacles to the pace of improvement in my world, quality improvement, has been the celebration of individual clinician autonomy and adjustment when we're seeing the patient. As a doctor, I want to be able to make the final choice as to what the patient gets. But we know back from the research of Jack Wenberg 30 or 40 years ago, and even prior to him, that this culture produces phenomenally large levels of variation. We're talking about 400, 500, 600% variation in the use of surgical procedures, medications, diagnostic tests, hospital beds, well documented. We tolerate it because we know that embedded in that variation is some good judgment by individuals. But I think we have lost a sense of how valuable it can be to settle down together as a clinical community, an expert community, and agree on what to do together the same way. And if we want to vary it, let's vary it systematically so we can learn from the variation. That's not what we're seeing in the COVID-19 world. Not what I'm seeing. I'm seeing clinicians reach out to each other. Who knows something about this that I don't know? How has Singapore done what they've done? Who knows about proning? How can I find out more about whether steroids should be used or not? This inquiry, this global inquiry, which I experience through the number of social networks that the Institute for Healthcare Improvement is managing now, it's stunning. People want to know what the best is so they can bring it to their patients' service. I don't think we'll ever see variation go away, but I think we might want to celebrate and reflect a bit on how good it is to ask the questions together and settle in on what we do know and how to put that into action reliably.
Where I see tension around that issue has been in the various therapeutic options that have emerged. That's where I see a great deal of the tension. So, Andrew Khalil from Nebraska wrote that, you really want to put people in clinical trials. And then, Derek Angus wrote, well, you want to put people in clinical trials, but you have to be respectful of the clinician who wants to make patients better. So then you have chloroquine, you have TOSI, you have the antiviral agents, you have steroids with almost no clear answer yet. And so it's that tension of trying to learn, but to do simultaneously. How do you reconcile that, Don?
A couple of ways. First, as a clinician in my past, I do think there's some strong merit in letting me as the clinician at the final moment decide what's needed in this local circumstance with this patient this time. I really want to preserve a lot of that. But the variation we observe is it's so large that it can't be right. It can't be that everyone's right. And if it's chaotic and not orderly, we can't learn from it. So you want to use A, I want to use B. If we just go blindly into our own world and do that, we'll never know whether A or B is actually better. But if we commit to standardizing around A and standardizing around B and then doing the proper data collection, we can learn a lot. It doesn't always have to be done with randomized trials, and I've talked about this
right.
a lot.
Uh-huh.
I really believe that the ascendancy of the randomized double-blind clinical trial as in some people's eyes, the only way to learn has cost our patients and ourselves dearly. It is not the only way to learn. It's not even the right way to learn in complex environments, and we have to learn more about that epistemology. But learning is crucial, and there are ways to learn dynamically from the kind of pace that we talked about earlier about tempo that really will add to our store of knowledge. Howard, it's a balancing act. We don't want to handcuff clinicians, but we should tie ourselves to continual learning through disciplined methods whenever we possibly can.
I do think, since we're reviewing literally hundreds of papers a week, we're better now at data collection. How we analyze those data, I think, is less clear. But we're now seeing generally high quality observational studies on some of these different therapeutic regimens, and we may not end up getting to the truth that a clinical trial will give us, but it will really help us as we go forward.
Yeah, I have a rather personal story about this. My daughter is a hospitalist. I'm so proud of her, and she's taking so many risks every day. She just does it. But I was talking with her last night and saying, "How's it going, honey?" And she said, "I'm less scared now than I was. Before," she said, I couldn't really tell which patients were going to do worse, which patients were going to do better. Everyone was a potential disaster. And as I was talking to a patient, I always had to wonder, is this person going to be intubated in 6 hours? She said, "I'm getting better at it. I now know so much more that will help me tell the trajectory that this person will follow." Now, that's an individual physician learning as she goes, probably with her colleagues. But that dynamic process of I'm getting smarter every day through the use of data, just like you said, it is learning, it is science, it is disciplined, and it helps. And I hopefully the new normal will be that we'll learn to do more about that.
The third is an absolutely painful section that you write about protecting the workforce. Will the new normal address more adequately the physical safety and emotional support of the healthcare workforce in the future?
Yeah, we physicians and nurses, the professionals, we're very privileged. We're privileged economically. We're privileged in the prestige society gives us, and a lot's expected of us. But I think there's some feeling I have that even pre-COVID, but now in some ways we've lost the commitment we need to the pride and joy of that workforce, and frankly even more to those professionals who don't quite have that social status or income, the people working in the pharmacy or in the laboratory or in the keeping the rooms clean. Boy, in any service industry, let alone healthcare, if you lose pride among the workforce or joy, the people being helped aren't going to get helped as well as they otherwise could. So it's protecting the workforce is it's something we should have been doing all along. Injury rates in healthcare and nursing especially are as high as they are in loggers. And we haven't really addressed safety of the workforce systematically over the past decades. Well, now it's come to a real head as we watch these young physicians and nurses go to work with no adequate N95 mask or protective equipment, and we ask them to do it, and we celebrate and cheer them that they are. That we shouldn't be taking pride that we have to cheer them to be courageous heroes when we have ways to protect them. So I hope this is a turning point, and one of the new normal themes is that healthcare should be the best possible place to work, the safest, the most joyous, the most collaborative, and hopefully we can remember that when this is passed.
Yeah, other than the early years of HIV, I don't think I've ever been prouder of the profession in terms of people saying, I will risk my life, ill-prepared, I will risk my life to care for others.
There's another sub-theme to that, which has to do with those heroes who aren't in the prestigious professions. I actually do think of it when I go to the grocery store now. And that's become a meme. Aren't these heroes the people in the grocery store showing up to serve us? Well, number one, they may have no choice given the regressive economy we have. They're not the people that have choices. And if you look at who's losing jobs in this economy, the job rate loss among people under $30,000 or $40,000 a year is phenomenally higher than people who are earning even $70,000 or $100,000 a year. So yeah, let's celebrate them. Let's thank them. But let's remember that equity, as we'll talk about later, it's not an event. It's a social commitment. And I have a new sense of what we owe these people, and we owe them in the long run, not just in the short run.
The next section has gotten a lot of press already. You titled it Virtual Care. It's obviously telemedicine, telehealth. COVID-19 has unmasked many clinical visits as unnecessary and likely unwise. Telemedicine has surged. Social proximity seems possible without physical proximity.
Yeah, I mean, I don't want to get into trouble on this one, but I think we built the habits of encounter in healthcare around history. Hippocrates saw patients in his office, I imagine, and around finance, because you get paid to do stuff. When doing stuff means you're physically with the patient. I've long suspected as a pediatrician, and I trained in internal medicine before peds. I think a lot of what we do and call for encounters is not helpful. It's wasteful. I hear immediately the kickback from my colleagues in primary care saying, oh, no, you need a relationship, you need continuity, you have to have face-to-face. Yeah, sometimes for some people, but not necessarily for everyone all the time. And so the periodicity we have established around well checkups, or for come back and see me visits, or I think these are not products of science. And now we're learning quite well how to do an awful lot of care, psychiatric care, dermatologic care, all sorts of primary care, through the way you and I are now doing, seeing each other today. And it works. It seems to work really well. Now, we need more hard-headed evaluations. Over time, we're going to learn a lot more about safety and processes in telehealth and telemedicine, but I'm stunned by it. It appears at two levels. One, the lingo I've learned is telemedicine means seeing the patient virtually, and that we're doing a lot very well right now. I don't think we'll ever go back fully. And then telehealth is the term I use to mean coaching clinicians in how to take care of people they otherwise might not be comfortable taking care of, like Dr. Sanjeev Arora does from the ECHO project in New Mexico. Both are thriving now, and I don't think I think this is going to be good for everyone.
Well, Don, you were at CMS, so you know healthcare finance as well as anyone in the country. And
yeah.
I spoke to Sherry Gleed last week, and David Cutler's on our board, and John Ianian's head of JAMA Health Forum. Will money follow? At the moment, there's been a lot of changes. So Medicare, Medicaid, private insurers are willing to pay for it, but they're not going to pay the same amount. Do you have a sense of what will happen with the financing and telemedicine?
I don't know. I'm thinking back to when I was administrator of CMS, and I was very kind of hooked on this at the time. I was already familiar with a lot of telemedicine gains, and I remember going to some of the staff saying, all right, well, how do we deal with telemedicine? What do we do here? And they said, well, what kind of a visit is it? That is, where does it fit in the current coding scheme? And the undertaking was to figure out how to code it as if it were a visit.
Right.
And the whole thing, well, it's not. It's something new. Can we figure out a way to do that? That's going to take more regulatory and statutory change, I think. CMS has agreed to pay for telemedicine just last week at the same rates as visits for now, for a short time. I don't think that's the right answer. The costs of production of a telemedicine visit are different. We need to find ways to reduce costs while improving quality. This is one. So I hope we can come up with an economic and financing scheme that will be respectful of the resources needed, but also respectful of the much too high cost of healthcare. Where it's going to go, I don't know. You're certainly going to see hospitals and clinicians ask for payment at pretty high levels. That's what they're used to.
Yeah, the term I've heard that people have written in some of the pieces I've read is payment equity. That you are correct.
Yeah.
That the production costs are lower, so to expect the same type of reimbursement will only increase healthcare costs.
I think that's likely to happen. We'll see both face-to-face visits and telemedicine visits increase. But no, we need a different payment theory here. It will not be easy and won't be welcomed by all, but in the end, we'll be better off.
Preparedness for threats. People have written about this. Your comment, the foundations of preparedness, most crucially a robust public health system, have been allowed to erode or have never been laid in the first place.
Yeah, there's two thoughts in that. I had the privilege of co-chairing with Ken Shine a National Academy of Medicine expert working process in 2018, which assembled literally hundreds of experts on preparedness. The charge came from the Assistant Secretary for Preparedness and Response, ASPR, in HHS, who wanted the help of experts to determine how prepared we were for 21st century threats and emerging infections, and especially how prepared the private sector was, because you can't do it just for the public sector. That report was published in JAMA, or our paper was published in JAMA in January. It wasn't at all reassuring. We knew, and in fact, there were many prior reports showing that what happened is what was going to happen, and we just haven't invested in that level of emergency preparedness. We could. It's a balancing act. You can't spend everything on that, but we sure can do better than we have. And there will be another virus, and there will be other kinds of threats, and it's time to take that seriously. We need a national government that's going to take it seriously, as well as regionalization that matters. The second is the public health structure itself. That's the vast infrastructure for doing what we need to be doing in public health anyway. Without COVID here, people are dying unnecessarily because we don't have public health as a major investment. That's a public-private sector partnership issue and an investment issue. We're way behind in those investments. So preparedness for a disaster is not the same as a strong public health system. They overlap, and we need both.
Yeah, well, it's clear if you look at what happened in Taiwan, Hong Kong, and Singapore, this notion, you and I talked about it before we started, this track, trace, test, and quarantine. It's almost impossible in the U.S. without a much larger public health infrastructure, which has been stripped bare over the last decade or two.
Yeah, in the nation, that means investing in CDC, of course, as our gem, and worldwide. I would be remiss not to mention the crucial importance of WHO. Criticized for some lapses, like all large organizations can do, but this idea that at this time, anyone in our government would question the value of the World Health Organization to the world is insane, and that needs so much more support than it's getting now, from now on.
Okay. The last, before we get to the conclusion and some other questions, is perhaps the most painful: inequity. Perhaps the most notable wake-up call of all is inequality. As the worm in the heart of the world, students of either health or justice are not at all surprised to read headlines about the unequal toll of COVID-19 on the poor, the unrepresented minorities, the marginalized, the incarcerated, the indigenous peoples.
Howard, when will we change? I mean, you and I know from our careers that structural racism, vicious economic inequity, exploitation of people at very low income levels, vilification of the other, people who don't look like me or sound like me. Now with this president fighting at our borders, people who just want to be well, this has got to stop. It is so much bigger. Look, I understand why this is edgy. It's so much bigger than a vaccine. We're talking here about things that take the lives of millions and millions and millions of people in our country and abroad. When we look at the COVID statistics, I think it's now, what did I just read today, 2.7 times higher risk for African Americans than for whites of death. The numbers in Chicago, I quote in the paper, when I wrote the paper, Chicago was 30% African American, 68% of the Chicago deaths are African American, and that's city by city. We've got to stop this. And I think COVID is there are local questions like how can we stop it in the context of this pandemic? That is important to ask, but that could almost be a distraction from the bigger issue about why are we tolerating this level of inequality in our society, and when will we stop it? I intend to work hard on this as I possibly can, because it's not the country we should be.
So, Don, over the last, the types of articles we've gotten have come in waves. So up to maybe a week or two, it was about all the different treatments. I only regret not having kept a long list of all of them, maybe 100. And then over the last week or so, it's been how COVID-19 is going to change this aspect of medicine, that aspect of medicine, CME, telemedicine. One came in today, screening for cervical cancer. Disparities have been with us a long, long time. I was at Boston, the old Boston City Hospital, and you write that for people who've observed the world in terms of justice and equity, this would have been predicted and expected. Why or how will it be any different this time?
I fear it may not, Howard. COVID-19 is, someone told me the other day, COVID-19 is like watching a group of 8-year-olds play soccer, and everybody, wherever the ball is, they're all going to go there. And sometimes the right thing to do is to run to space. You go where the ball isn't. And I keep thinking about what are we neglecting now? What are we not doing because COVID's so attractive? When COVID goes away, what are we going to have the energy to work on? Whether we're going to do something different this time, I don't know. It is political. I think that scientifically, I don't see a route to the correction of this vicious inequality that is not redistributional economically, where we understand that the wealthy, we in society, have got to look at our neighbors who are in much worse circumstance and say we need to give more so they can be better. I understand all the political edge to that. I understand the alternative market-based theories. I understand the blame that we cast at people of disadvantage. But I don't think there's another way. We have to find generosity again in our society. We see it on the streets. I point out in the paper when you put on a mask, you're not really protecting yourself. You're protecting other people, and everyone's doing that. So I have some hope that with proper leadership, we can be awoken again to our solidarity.
Sandro Galeo last week, it came in before the pandemic, wrote a piece about, social determinants of health and health equity. And I think I really liked it because he talked about how much is owned by society in the political process and not necessarily healthcare, and that the grander solutions will come through the political process and not what individual physicians or hospitals do.
Yeah, I've spoken and will write, if you'll let me, about what I call the moral determinants of health. The social determinants of health we now know. We understand structural racism, forms of economic disadvantage, environmental threats, problems in our education system, housing, food security. We know those chains, all of which poverty, inequity, and racism are behind. The question I have is, well, where does the energy come to fix it? The question you asked me, and I believe it's going to have to come from a moral compass. We're going to have to return to some sense of what is right. There are economic arguments you can make. It's better for the economy if we don't exploit people of color. Probably yes. But if that's where we turn for motivation, we're not going to have enough motivation. We've got to ask, who do we want to be? And that's what COVID's asking us.
The last couple paragraphs are about the world, which is a little different. And I like them. I'll read a few. The temporary effects of the pandemic on carbon emissions and pollution are large and instructive. The planet is, by that measure, a healthier celestial body.
Yeah, that paragraph goes on to say, I read in a paper that people in Kathmandu can now, for the first time in decades, actually see the Himalayas. I remember being in Kathmandu with my eyes tearing and the smog, you couldn't see a thing. Automobile accidents are way down. So a big issue here is the climate lessons that we may learn from COVID, if we want to take those lessons. And equity is a global issue. Again, we have to understand that wealthy nations have to help less wealthy nations, and that is going to be another question before us as a planet.
Before we close, a couple more random questions, Don, only because of your extraordinary experience over the years. Joe Biden's recommendation to lower Medicare to 60. Someone said, did you read it? And I hadn't read anything. We have a viewpoint coming out about it. It fell somewhere off my radar scope. To me, it was a big announcement. What's your sense of that, Don? Will it help? Is it politically viable?
Yes, it is, and yes, it would help. I think when I'm asked, as I'm asked often about policy choices, and as we move toward the 2020 presidential election, I think we'll see a return to the screen of policy choices. I say there are 4 questions. You show me a policy, I'll ask 4 questions. Number 1, does it move us toward universal coverage? For Pete's sake, let's make healthcare a human right.
Right.
If it's and that's a step. Second is, will it improve quality of care? We have serious issues with quality in this country, patient safety and others. Can we use it as a lever for making care better, especially for chronically ill, mental health care, and so on? The third is, will we move towards social determinants? Will we take Sandro Galea's analysis seriously? How will this help housing? How will this help the poor? How will this help address food security? And the fourth is, will it reduce costs? I absolutely believe this country could have all the care we want and need for everybody at higher quality at something like 15% of GDP, not 18%. So we have a ton of waste in the system. So those are the 4 questions I ask. Yes, lowering the Medicare age would be a step in that direction. But I need to make one point, which I also would love to write up. Here's a pop quiz. Who in America today isn't worried at all about the economic consequence of COVID in terms of healthcare costs? Who doesn't have to worry about healthcare costs? Well, the VA does. Veterans don't, more or less, and nor do beneficiaries in the military health system. That's one. But the biggest lump of people that don't have to worry about the money are Medicare beneficiaries. Right. They're the only people that don't have to worry. Medicaid is under siege, and it's harder to enroll. The exchange enrollments are now, you have to have a time it right, and the coverage is not as good as it used to be. Commercially insured people, well, 24% of the employed population of Massachusetts have lost their jobs, according to the Boston Globe the other day. Where are they going to go? Get COBRA coverage? You try to afford COBRA coverage, even with subsidies, and COBRA goes away. Everybody has to worry about where their health care coverage is going to come from, except Medicare beneficiaries. You want to think about that for a minute? And doesn't that tell us something?
You touched on it, and I spoke with Sherry Gleed last week, and we have a couple of viewpoints. I'm really concerned about the future of Medicaid. Costs are going to go up. State revenues are going down. It's a numerator and a denominator. Massachusetts, if you factor in what they pay for the state employees, the pension plan, healthcare costs could be almost 40% of the state budget between Medicaid and those other costs. What do you see as the future for Medicaid?
Well, first, we need presidential leadership to make Medicaid robust. It is the nation's safety net for people that really need it. 14 states have not expanded Medicaid under the Affordable Care Act. They all should expand. We got to make that happen. This is leaving very poor people up a tree. And then, unfortunately, under current federal policy, Medicaid benefits structures are being eroded. Work requirements are entering the picture, throwing some people off Medicaid rolls if the courts don't oppose them. We have states are being given permission to erode the Medicaid benefit structures. States are now able to make it more difficult to stay on Medicaid, requiring more hassles than are appropriate for the people that have to bear that burden. You're right; it's under serious threat. And the big picture on the right is to try to get Medicaid to be block granted, where the federal government says, we're kind of out of here. Here's your money. Bless you. Do what you want. We have experience with block granting. We know what it does, and it degrades Medicaid. And imagine now, at a time when people are falling off their employment, and we could be entering a great recession again, or even a depression. Do you really not want the federal government to be there as the counter-cyclical support for people that are really in trouble? Because that could be you tomorrow. So you're right. It's at serious risk, and I think we need to recommit to the purposes of Medicaid, which is to make sure that the nation has the back of the people who are at most disadvantaged.
The series is COVID-19 Beyond Tomorrow. Crystal ball for the fall. That's what the series is focused on. Schools, college, business.
There's a report out that everyone should read from the Massachusetts High-Tech Technology Council, MHTC. I would urge people to read it because it's discussing options around graded opening, and it makes sense to me, as I'm hearing from other states too. Yes, I think schools will open. I think that the burden of not having children in school is going to be enormous. I'm worried about teachers and the adults who are in contact with those children. We need to think that through, and it should be done in an evidence-based way as possible. Some gradation of opening the economy to people at lower risk. But every single model I see today, Howard, and remember, I'm not an epidemiologist. I don't know the mathematics the way I did here. Every model that I see shows another wave coming. We will reopen, loosen up, and then we're going to say, uh-oh, it's coming back, and we better have the discipline to go back into forms of sequestration and distancing that make a difference.
Yeah, I spoke to Ann Schuchat last week from the CDC, and I think Ann, along with Tony, are the people who have the most experience with epidemics and pandemics over many, many years. Tony, obviously, close to 40 years. And I think that, there's concern now with the states opening up, but the great fear is the fall. In part because of flu and combining flu with other winter diseases with potentially COVID-19, we could be back where we are now. No one knows, and I think that's where there's a lot of uncertainty.
Yeah, the key will be track closely, test as much as we can, know when it's coming before it's hit us full force. That requires a real investment in the public health infrastructure we were talking about before. Yeah. Let's not be caught on our heels again, for Pete's sake. And we need leadership from all levels of government now to make sure the public health structure is waiting and ready when we need it. Of course, it isn't over yet. There are parts of this country that have not yet seen their peak. Massachusetts is at a plateau. So we shouldn't celebrate too fast that this particular wave is going anywhere. We got some work to do. But if and when we go down to a nadir, we better be ready. And I will, as responsible as this government is for what has happened to date, it'll be doubly responsible if we get hit by a second wave and aren't prepared for it.
I want to read two last sections from the viewpoint, and then Don, you can have the final word. Fate will not create the new normal; choices will. And then you conclude with the final words. Most important of all, is this the time for equity, when the evidence of global interconnectedness and the vulnerabilities of marginalized people will catalyze at last the fair and compassionate redistribution of wealth, security, and opportunity from the few and the fortunate to the rest? This virus awaits an answer, so will the next one. Don, you get the final words with the interview.
When I was in federal government in the Obama administration, one of the words that was most difficult to use was solidarity, because it somehow invoked images of socialist or communist other countries, that individuality and personal success was the American watchword, although we certainly can exhibit solidarity in wartime or when there are threats. This is a question for us. Are we willing to not just to accept, but to celebrate being responsible for each other as a characteristic of a strong and healthy country? We better. There isn't really another option that leaves us whole and well. So I guess my last word would be, please, let's recognize that we're interdependent, whether we like it or not.
This is Howard Bachner, Editor-in-Chief of JAMA. This has been Conversations with Dr. Bachner. And I've been talking to one of the most remarkable individuals I get to interact with on a regular basis, Dr Berwick, President Emeritus and Senior Fellow at the Institute for Healthcare Improvement, but more importantly, someone who I can call a friend and a colleague. Thanks, Don.
Thank you, Howard.